Okay, screen sharing paused. Hang on. Okay, there we go.
All right. So, welcome everyone to our post-professional occupational therapy doctorate capstone presentations here at Elizabethtown College. We have quite a few this year, and we're excited to have our afternoon and evening today with many wonderful presentations. We're going to kick it off with Nicole. She has focused on both trauma, autism, and taken some strategic leadership and business classes as well. She owns her own private practice and is doing some really innovative things with pelvic floor folks with Ehlers-Danlos and trauma. So we're going to kick it off with her, and I'm going to turn it over.
All right. Hi, everyone. Thank you all for being here today. My name is Nicole Woodruff, and today I'm going to be focusing on the role of occupational therapy in treating pelvic floor dysfunction in clients with hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder. So I am an E-Town alum, just a little introduction here with over 12 years of experience, and I specialize in both pelvic health and chronic condition management. I opened my own practice this past June to focus on those things specifically, and I have a personal connection to these topics being covered because they affected my life for basically my entire life. So I was diagnosed with Ehlers-Danlos syndrome last year and POTS, and I've now really dedicated my practice to treating these things. So, what is hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder? So, they are connective tissue disorders characterized by joint hypermobility, chronic pain, and multisystemic symptoms. Pelvic floor dysfunction is a common issue among people with these conditions, and this can often impact quality of life. So, in regards to EDS, there are 13 different types. Hypermobility type is the most common type, and the other 12 have a genetic marker that you can test for, but the hypermobility type you cannot. So, it is a clinical diagnosis, and there are a lot of comorbidities that occur with this condition, with both of them. And a lot of those include postural orthostatic tachycardia syndrome, mast cell activation syndrome, GI dysfunction, migraine headaches, TMJ, other types of dysautonomia, chronic fatigue, and honestly, the list kind of goes on. So, HEDS or HSD, I refer to them basically synonymously throughout this presentation. So, I just wanted to take a moment to explain the difference. There is not a big clinical difference in how they're treated, it's just how they're diagnosed. And so, because it is a clinical diagnosis, there is a Beighton scale that is used for diagnosis. And if you score, I will show you here, 5 out of 10 or 5 out of 9 on the Beighton scale, it is a positive result for generalized joint hypermobility. And then from there is where the physician would determine if you meet criteria for HEDS or HSD. Really, they're treated the same. It just depends on the other criteria that you have. So often these conditions are either missed or delayed for many years. Myself included, it took me 34 years to get a diagnosis that was there my whole life. It's genetic, so you are born with it. And there's really just a lack of understanding in the medical community about hypermobility disorders in general. They used to be considered rare conditions with prevalence rates at like 1 in 5,000, but a lot of recent studies indicate that they are more common than we think. So it is important to recognize and have the ability to screen clients for some of these symptoms when you see them. So EDS and pelvic floor dysfunction tend to go hand in hand, and that is thought to be caused by abnormal collagen in the pelvis. These are some common pelvic health conditions that you might see in somebody with a hypermobility disorder. And they include pain, bladder symptoms, prolapse, basically anything you can imagine. And in addition to EDS and the collagen aspect of it all, there's two conditions that very commonly occur with EDS, and they are POTS, which I mentioned before, and then mast cell activation syndrome. These are both very, very common. They often are known as the triad or the trifecta with these conditions. And those two can also contribute to pelvic floor dysfunction as well. Mast cell activation activation syndrome in particular, there's a lot of mast cells that line the bladder. So some people will have a lot of bladder irritation. Interstitial cystitis, bladder pain syndrome, vulvodynia are all very common and linked to mast cell activation syndrome. So there is no standard treatment protocol for hypermobility conditions, but research does highlight the importance of a multidisciplinary approach. Patients really want providers who are open-minded, who are not judgmental, who will actually listen to them and take their concerns seriously. And OTs really fit in well with this type of provider because we do provide that holistic client-centered care, and we use the biopsychosocial model to approach treatment. So the role of OT in chronic illness. So we can, provide treatment to focus on ADLs and all of our daily activities and the impact of chronic illness across our roles, our routines, our general quality of life. The AOTA OT practice framework added health management as an area of occupation in the 2020 edition. So there's really so much that OT practitioners can offer those with chronic illness, but we really need research to say how we help. So the OT's role in pelvic health is gaining recognition. The AOTA is starting to actually put out communities of practice for us, where we have a statement hopefully coming in 2025. And again, the biopsychosocial model is a big reason why OTs fit in well with pelvic health and chronic illness, because we use this naturally as practitioners, and it really helps clients feel seen, heard, and supported by healthcare professionals. So methodology. I did a case series and on 3 of my clients, and I chose this as a way to really kind of dive deep into the intervention process and the differences between the clients and track patterns. So I received IRB approval from Elizabethtown College, and I started my research back in September. So there was about 4 phases of research here: recruitment, then I had the baseline assessment, and sorry, I lost my note here. Baseline assessment, my interventions, and my post-assessment. So the 3 women met inclusion criteria and provided informed consent. And basically, they were all asked similar screening questions. Did they have pelvic health concerns? Did they have hypermobility, or did they have a diagnosis or suspect a diagnosis? One thing I want to note is that individuals who did not suspect a diagnosis were obviously not included, but for those that suspected they had one but weren't officially diagnosed, they were allowed to participate based on the fact that so many people with these conditions are not diagnosed, or they are misdiagnosed until later in life. So, but all 3 of these women were I'll get into the cases in a moment. So these are the pre-intervention assessments that I used, and that was the SF-36, the pelvic floor impact questionnaire, the pelvic floor distress index, and the vulvar pain questionnaire. So they all looked at quality of life and the impact on daily occupations, that sort of thing, across different measures from pelvic floor dysfunction to chronic illness factors. So intervention focused on individualized treatment, and I documented each session and recorded the types of interventions we used and the intensity of treatment. So then afterwards, we did our post-intervention data analysis. I re-administered all of the baseline tools, and then we did pre and post-assessment comparisons, and I tracked for trends in the data for individual progress and themes across clients. So getting into the bulk of it here, client A was a 38-year-old primiparous female. Her primary complaint was that she had bladder spasms and urethral burning that worsened at night. And her medical history included recurring UTIs. She knew she had hypertonic pelvic floor because she had been seeing a pelvic floor therapist prior to coming to me. She also was seeing a vulvar pain specialist who had screened her for hypermobility and scored her 5 out of 10 on the Beighton scale. She was on the waiting list to see a physician who specializes in both EDS POTS and mast cell activation syndrome, and she is going to be seeing that physician in the next few months. She had a lot of comorbidities that you often see with these diagnoses. She admitted to having a very high stress lifestyle with her job, and that influenced her symptoms often. Her daily pain was about 4 out of 10, and the impact of daily life was 8 out of 10. She had a lot of postural issues and shallow breathing pattern. Her glutes were not activating appropriately when tested, and she had a lot of tension in her hamstrings as well. In her pelvic floor muscle, she had increased tension across the board, definitely in the levator ani group and on the right side greater than the left. These were her pre-intervention SF36 scores. So I meant to say before, the SF36, if the score is lower, that shows a higher impact on quality of life. So if the score is higher, that person has a better quality of life, better health. So these are lower here. And then these are her pelvic floor questionnaire measures. And so two of them are scored out of 300. And so she had a pretty significant impact across the board on two of them. And then the vulvar pain questionnaire is only out of 33 points. So it looks a little skewed in this graph, but she scored an 8 out of 33 on that one. These were her goals, client-centered, focusing on pain and improving occupational performance. I don't want to go too deep into all of that, but the intervention piece is really important. And across each client, you'll see I kind of put everything into like 3 different buckets where we focused on treatment. Client education was one of the biggest ones, and that included things from like breathing strategies and nervous system regulation techniques. It included ways to habit stack your movements into your daily routine so that it doesn't feel overwhelming. It included things like toileting position, using a pelvic wand to do self-release of your pelvic floor muscles. And then for her, also managing POT symptoms and noticing her trends with her stress and how that relates back to her pelvic floor symptoms. And then we did a lot of manual therapies for people across all 3 cases. And that helps with usually, and even having the firsthand experience as somebody with these conditions, it does seem to help with tolerating the exercises more and decreasing the muscle tension that they're experiencing when they're doing the exercises. So, and then we paired that with neuromuscular reeducation and therapeutic exercises and focused on postural stability and awareness and really improving glute activation and her biomechanics throughout daily life. This is her progress. So her pain decreased from she was 4 out of 10 to 2 out of 10 at the last session. I want to note that this client received 4 sessions and the other 2 clients I'll be getting into received 8 sessions. The study was up to 8. She also improved her body awareness and her proprioception, energy and confidence in managing her symptoms, and improved her occupational performance in the areas that were impacted by her symptoms. And as you can see, these are her SF36 scores post-intervention. They shot up across in every category. She improved. And then these were her post-intervention pelvic health scores, which also decreased. So that indicated improvement across the board here as well. So client B is a 30-year-old nulliparous female. She was a nurse practitioner. Her main complaint was coming in with pain with intercourse. So she had pain with intercourse for over 7 years and a lot of symptoms that affected her relationship with her spouse. She had hypermobility spectrum disorder, was actually diagnosed during the study, but she came in with a previous diagnosis of POTS and had suspected hypermobility. She also had lipedema and PCOS, chronic low back pain. She was working with a sex therapist when she came in to see me, and she reported that her stress levels were actually pretty low. She had amazing health habits and really good self-care practices, 8+ hours of sleep at night. So she was really taking good care of herself. Her pelvic pain on average during intercourse was a 6 out of 10, and the impact on daily life she rated at 5 out of 10. She had a limited thoracic mobility. Again, we noted the shallow breathing pattern. She had decreased glute activation and decreased muscle activation in her glutes once again, as well as tension across the board in her lower back and her pelvic floor muscles. And we were able to replicate her pain with intercourse with palpation of the introitus right at the opening 6 o'clock at the of the vaginal opening. That was exactly where she had her pain. So at the Beighton scale, she was a 6 out of 9, and her occupational performance deficits were across these categories, mostly affecting the sexual activity. And so these were her pre-intervention SF-36 scores. As you can see, they are pretty high compared to client A. She was mostly limited in her role limitations affected by physical health. And then these are her pelvic floor measures. So it looks a little bit different than the last client. As you can see here, she had a 0 out of 300 on the 1 score. So she indicated no issues with colorectal or urinary or prolapse concerns, which is what that scale really assesses for. She had a very low score on the PFIQ-7, and that was mostly due to just the emotional factor of her symptoms. And then on the VQ, she scored a 7 out of 33. So these were her goals. Again, client-centered, focused on relieving pain and improving occupational performance. So intervention, again, focused on those 3 same areas of care: client education, the manual therapies, and then neuromuscular reeducation. We really focused on improving her mind-body connection with her glutes to properly support and decrease her lower back pain and calm down the muscle tension in her pelvic floor. We used a lot of different manual therapy techniques prior to the neuromuscular reeducation and exercises. And with her, we also did a lot of guided meditations and body scans and really focusing on just continuing to downregulate the nervous system. So her progress, so from the start being a 5 out of 10 during the evaluation, when I palpated that superficial muscle layer, was a decreased to 2 out of 10 in our 8th session. Her back pain was almost pretty much gone after the 8th session. She was feeling so good. She demonstrated much easier recruitment of her glute muscles and much better biomechanics with better hip hinging form and core activation through her daily activities. These were her SF-36 scores after the 8th session. So it showed much improvement in all areas, even though she was doing pretty well even to begin with. And then her pelvic floor scores also went down on the PFIQ-7 and the VQ from the limited scores that she did have to begin with. They went down. Last client here is a 34-year-old nulliparous female. So she was a writer and an author. She had a hypermobility spectrum disorder diagnosis coming in. She came in with pain. She was referred for basically chronic upper extremity pain, but she had secondary concerns of a history of pelvic pain and painful intercourse. She had a lot of comorbidities that we see again with these diagnoses. Her daily life impact of pain was a 5 out of 10, or sorry, pain was a 5 out of 10. Impact on daily life was an 8 out of 10. She also had a lot of postural deficits, a ton of muscle tension in her upper body, decreased strength throughout her shoulders, grip strength, range of motion, and all was normal. These were her occupational performance deficits, definitely affected more of personal hygiene, grooming, like blow drying her hair, and her job performance. Also some issues with health management and maintenance, and then leisure and social. These were her goals, again, decreasing pain across the board, improving occupational performance, using compensatory strategies and ergonomic modifications as we need to. So these were her SF-36 scores at baseline, and these were her the pelvic floor questionnaire scores at baseline. I didn't end up doing the VQ questionnaire with her just because she did not really have as many pelvic floor concerns at the moment. And that's one thing I wanted to mention here is the intervention. I focused on treating what she came in with. Even though she agreed to participate in my study and we noted what she had going on with a previous history of pelvic pain, using a client-centered approach, I really could not take my OT hat off. Even though we talked about pelvic health, I really just had to meet her where she was and treat her primary symptoms first. So we focused on her upper extremity pain. For her, again, we used that mind-body connection, neuromuscular reeducation, and that really had to do with activating some muscles in her shoulder blade area that just were not working at all and calm down some of the tension in her upper shoulders. This was some just notes on the strengthening progression that we used. A lot of people with EDS are fearful of moving and exercising, so we had to address that aspect as well and make sure that we weren't doing end range exercises to end range to prevent subluxations. Her progress here, she decreased from pain 5 out of 10 to 2 to 3 out of 10. And then her activity tolerance for typing also improved quite a bit. So occupational performance improved, her body awareness improved, and proprioception. These were her SF-36 scores. So every area improved besides role limitations due to physical health. And that is because she's still working on, modifying her job responsibilities, and being in front of a desk and working at the computer is still challenging. So, and her pelvic health scores improved as well, just from some general education, maybe coincidental, but we didn't really do anything with the pelvic floor actually during the study. So, discussion, I'm going to try to go through this fast. Similar diagnoses do not equal similar symptoms. So, each person had pelvic floor dysfunction, but all of the issues were really different across the board. And only clients A and B had symptoms that were severe enough to really impact their occupational performance. And that was really different even between those two. So treatment really must be individualized and affect the whole person. So impact on occupational performance, client A, again, we decreased pain and we improved her sleep, her home management. Client B, improvements in sexual activity, health management, and IADL. She didn't have back pain anymore when taking care of her niece and nephew. And client C, we decreased her upper extremity pain, and that improved her job performance. So this was one of the most interesting findings across the board for me, is that the impact of pelvic floor dysfunction can really vary depending on the severity of your symptoms and your roles and your preferred occupations. So client C, who was not sexually active during the time of the study, she experienced her pain as upper extremity pain as a more pressing issue than her pelvic pain. Whereas client B perceived her pelvic pain as a considerable barrier in her intimate relationship with her spouse, and client A had bladder pain symptoms that really impacted her entire daily life, that were persistent, but they did not affect her intimacy with her spouse. So it's just interesting how it presents so differently for everyone. But across the board, client A definitely had the most significant impact on quality of life. Mental health and symptom severity. So stress really exacerbates symptoms, both related to chronic pain and pelvic floor dysfunction. We had a hurricane come through Florida during my study, and that really got people's stress levels up. So mind-body techniques are really important to incorporate, and trauma-informed care. Two more here. So manual therapies and neuro reeducation were a big piece of what I do and what I try to focus on. So that includes calming down some of the overactive muscles and then retraining the muscle groups that necessarily aren't showing up properly like they need to. And so across the board, combining these two interventions really helped all of my clients with their pelvic pain and upper extremity pain for client C, and they improved their functional scores. So this really aligns with previous research that suggests the combination of these two can work to reduce chronic pelvic pain. Breathing patterns and nervous system regulation was also something I noticed. Everyone had shallow breathing. Everyone had reduced diaphragmatic excursion. And so those could be a sign of central sensitization, which is common in people with chronic pain and chronic illness, and overactive sympathetic nervous system, which is common in POTS. So it's just something to note and keep in mind as an OT, that the nervous system regulation strategies and those holistic approaches that we use can be really important for people with these diagnoses. And then lastly, client education is super important. It empowers clients to take care of things outside of sessions, teaches them self-management strategies. We used a lot of different techniques and tools to use this, including videos, and I lent clients books. We used handouts, demonstrations, and all of them really felt empowered by knowing more about their condition and doing things on their own. So some study limitations, obviously a big one is the reliance on the self-report measures. There's a huge potential for bias here with those. Client A, for example, had a really significant first pre-intervention assessment measures, and then post were very different as well. And so that could be as a result of maybe a symptom flare prior to completing the first one, and then things were better. And then also with chronic illness, in a week, if symptoms flare again, those scores can look different. So that's always a little bit of a limitation. The sample size and the methodology, obviously being a case study, limits that generalizability. And then the therapist-client relationship can also influence the results. because I was the researcher and primary treating therapist, that can maybe cause bias in the client's responses on the questionnaires. And then some future research directions. Some I really wanted to touch on, maybe like an occupation-based measure on pelvic floor dysfunction's impact across quality of life and the roles that I was talking about, because it's so different person to person. Maybe additional case studies on these and survey research on the lived experiences of clients with these conditions. And another thing I really think I missed here was doing a post interview with the clients to really see what interventions they felt were most appropriate. Because it's such a combination of things. It'd be nice to know, okay, what made the biggest impact. So acknowledgements, thank you to my husband. He was so helpful to me throughout this entire process. To my parents, my mother-in-law for all their help, and to Carrie for your encouragement and support throughout this entire process. I really appreciate it. I have a million references, and that's it. Sorry, I am over a few minutes, but I had so much, so much here. So thank you. Um,
No worries on being over. How about any questions in the room? First, I'll tell you, you did a fantastic job. And yes, you did have a lot of information to get through in a very short period of time. I'm very impressed with the amount you did cover and the amount of time you had. Looks like Tam, you're
Yeah, I do
ready
have
to
a
go.
quick question. And so, hello, Nicole, and
Hi,
great job.
Pam. Thank you.
Yeah. I guess I'm just curious. You may or may not know this information or may not want to share it, but I
Yeah.
was curious. I think it was the your first case study, and she was going to another practitioner who was doing pelvic floor work with her.
Yeah.
So, did you have a sense of why she switched or why what was happening and if that work was a lot different than your work?
Yeah, it was actually like a colleague of mine who had left the practice. And so she just had like a gap in care. And in the meantime, she learned about my practice that I opened. And then I was specializing in these conditions that she thought she had. So she thought, she would come to me because she knew that I specialized in those conditions.
Okay.
So
Okay. Yeah, I was
yeah,
just curious. Yep.
yeah.
Thank you.
Thank you for the question.
Other questions? I just have time for one. So I really want to know what about the research process with this particular project surprised you the most?
The research process. You mean like the methodology I chose or the,
Yeah. Yes.
okay. I honestly, probably just like how much went into this when I went to
Mhm.
put it all out there. In my head, I thought that three participants was not that much, but then when I went to put it all together, it was a lot and a lot to go back and look at every session, look at every note, document everything, and put it all together and write it up as a case study. Yeah, it was expansive. So I hope that this will be helpful for other people in the future. I did submit to be a speaker next year at the OTs and Pelvic Health Summit on this topic. So I hope I get a chance to present it there.
Well, I wish you a lot of luck in that. I hope it works out. I will tell everyone that your initial idea was 6 case studies. And when we first started talking, and I'm like, no, we're not going to do six in 6 months. So congratulations to you. Your work is incredible. And I'm sure we're going to all get to say we knew you when.
Aw, thank you.
All right, we're going to stop the recording.